Hey, welcome to the Go-To Physio ankle series. Now, today we want to talk about how to assess an ankle joint and see how it's reacting with the knee, with the hip, and avoiding or maybe not loading certain parts of the body. So as always, it always starts in the subjective assessment. And in today's content, we're now going to take that and we're going to start to make sense of the patient's story in the objective assessment. So with that said, let's get started. Okay, so with the ankle assessment, usually, with an acute ankle injury, etc., the athlete, they may have some kind of swelling, etc. Now, the swelling is also a good determinant in terms of return to play. So personally, I'm not a big fan of letting an athlete go back running or training until that swelling has gone. Okay, so I think sometimes if we rush that athlete back through the swelling, I think things just get a little bit messy. As I said, motor adaptations tend to kick in, and I just haven't had good results with it early days. So what I will do is I'll work hard with the swelling. Now, in terms of evidence and stuff like that for ice, personally, I've seen clinically a lot of athletes get a lot of value with icing. Now, when I ice the ankle, I don't just put ice on the ankle. I get the athlete to put a basin of water, okay, and actually make sure there's iced water in there, and then the full foot is covered. Okay, now whether it's the pressure of the water that's genuinely helping the lymphatic drainage, I'm not so sure, but I've had great results when I actually cover the full foot in water rather than just applying ice. I haven't got great results when I just applied ice to the athlete, but a basin of water, and then I just chuck the ice in for good measure, and we can get the ankle to to reduce that swelling quite quickly. And again, that's based on 8-9 years. I don't need any studies to tell me otherwise. If I had an option of doing it or not doing it, I'd pick it every time. I've got great results with it, and it stood the test of time for me. So I'm more than happy to recommend putting that foot in a basin of water, and then I don't think you've anything to lose by putting ice cubes in there. Okay, so what we want to make sure, obviously, is we want to identify the tissues. Okay, so with the ankle, I might invert that ankle. Usually that'll be tender, and if it's an ATFL sprain, and the reason it'll be tender is because you're lengthening those tissues. Okay, so those tissues presumably are healing now, and by giving that little bit of inversion there, you're just going to stretch those tissues. And a lot of athletes actually, they'll have ruptured the ATFL, and Pete looks like he's one of those guys. Okay, and then usually I'll stick my finger in and I'll almost strum. Okay, and then you want to strum across, and I actually can't feel Pete's ATFL here as I strum. Okay, so usually when you strum, that tissue will be sensitive if it's an acute ankle sprain. Okay, so I'll just strum and then go, okay, is that the pain? Is that your pain? Great. So then we've got a fair idea. Obviously, I'm checking for the tip of the fib head, any tenderness there. I'm going to check the navicular, no tenderness, and then I'm going to check the base of the fifth as well. Okay, so if they're all okay, I'm pretty happy. And then I'm just going to strum through, and then I'm going to see. Okay, so again, if that's the case and we know it's ATFL, okay, I'm a little bit happier. Then what I want to rule out is that syndesmosis. Okay, so we've got two options with the syndesmosis. What I will do is I'll put the foot here, and we're going to use what's called a squeeze test. So with the squeeze test, obviously the syndesmosis ligament is right here. Okay, so it's between the distal third of the tib and fib, the interosseous ligament. And what we want to do is we want to squeeze the tib fib, so we almost have that chopsticks effect. So when I squeeze here, it's going to gap and lengthen these tissues here. So if there is some kind of tear there or trauma here, in theory, if I lengthen that tissue again, that's going to be positive for a pain response, because the tissues here, when they're stressed, they're probably going to give an nociceptive stimulus up to the brain, and the brain usually will quite rightly interpret that as danger, and we will feel that positive pain experience. Okay, so what I'm going to do is obviously be careful with the tib fib, because it's more of an oblique angle as opposed to a sagittal. So I want to come around here, and I'm just going to squeeze his tib fib. Now when I do that, I like to have my elbows here, so all my force goes through here, whereas if I'm here and I'm just trying to do that, I'm almost doing a pec exercise in the gym. Okay, so make sure your elbows are out, and then your force goes straight through. Okay, I've seen a doctor, a very well respected doctor, miss one of these in a dressing room before. Then he's gone away, or he's just stepped aside, and I've rechecked it, and the athlete nearly jumped off the bed. Okay, I'd rather you be aggressive with this and pick it up and aggravate it a touch than miss it. Okay, I'm going to repeat that again. I would rather you're aggressive with this test, okay, and pick up this injury and even just irritate it a tiny little bit more, even though the athlete's going to be in pain anyway, then under squeeze, okay, or be maybe a little bit more conservative and miss it, okay? Because if you miss it and you let him walk around in it, every time that foot hits the floor, there's probably going to be further gapping, okay, of the tib fib, okay? So then what you'll find is you'll have swelling, you might have some instability, etc., and they can, from experience, they're a nightmare to deal with. So again, the force is here, and then I'm just going to put a force through Pete's tib fib, and I'm almost springing here. And then any pain, Pete? Okay, so take up the soft tissue, give it a good squeeze, and then I'm looking to replicate any symptoms down here. If Pete feels pressure and pain here, that's absolutely fine. It's because I'm pushing here. But we're looking for the pain to be reproduced here. And as I said, make sure you know, you're not conservative with it. Okay, so what I'm going to do then, okay, if we just move over to this ankle for ease of the camera, is I'm going to do what's called a dorsiflexion external rotation test. So what I'm going to do then is I'm going to cup the calcaneus, put my hand on the knee, and then I'm going to ER basically that tib fib. Okay, so what that's going to do is that's going to cause that malleolus, okay, or sorry, the navicular bone, okay, to rotate, okay. Sorry, not the navicular bone, the talus, apologies. So it's going to cause the talus to twist. So when I do this motion here, okay, I don't know why I was saying the navicular there, the talus is going to rotate. Now when that talus rotates, okay, if this is the tib fib, that's going to cause those tissues to gap as well a little bit. So then usually we're going to get a positive pain experience with that as well, okay. So again, I'm looking, when I test, cup, twist, you know, give it a good twist, and then we're looking for pain around this area, okay? If the athlete can feel pain around this area, then we're suspicious that the syndesmosis may have been traumatized, okay? If the athlete has pain on the squeeze test and the dorsiflexion external rotation test, then I'm pretty confident that that athlete has some signs. Now, I would rather compress the athlete, offload the tissue short term, okay, or put him in a boot if we have a boot, okay, a walker boot, rather than allow that athlete to walk on those on that ankle, okay? So even if we don't have a walker boot, we've crutches, I would advise the athlete for the first 48 hours to non-weight bear until we know, okay? Now that's a situation where it's a pro athlete, okay? I appreciate with amateur athletes it can be a little bit trickier, okay? But if you want to do the right thing and give the right advice, in my opinion, offloading that ankle so that we don't continue to gap the ligament, so to speak, I think it's a good call, okay? Obviously, the athlete needs to make the decision if they've got work the next day, you know, if they're like with amateur rugby league, if they're working on building sites, etc., then, you know, they need to make that decision ultimately themselves, okay? But you can advise, you know, and your best practice for me anyways, in my opinion, is to offload the syndesmosis for a few days until we know exactly what it is. If we can arrange a scan, great, or, you know, we can get that athlete into a boot to stop further trauma to that tissue, because any weight bearing, we will have some load going through that syndesmosis, okay? So, you know, we want to give it a few days just to settle and not gap it, because as I said, the other big thing clinically that I see is the presence of a synovitis in the ankle joint. So synovitis is when the tissues get a bit inflamed, okay, and then that can really lead to delays in the return to play, okay? So, you know, if we pick up a synovitis, then that just usually, from my experience, it adds on to the return to play time. So we want to avoid developing a synovitis at all costs, and I think a lot of athletes develop synovitis in the joint with a syndesmosis because they have been walking around, and then again, that's just my opinion, so take that with a pinch of salt. But if we can manage it early doors, then, you know, we're flying, okay? Now, the other thing as well that we need to do, that we're going to check here, okay, so if we're suspicious of a syndesmosis, then there's a few other little nice tests that we can correlate this with, which I'm going to show you now also. Okay, so the next test that can be a big giveaway for a syndesmosis is a calf raise, okay? So if we consider with a syndesmosis that there's some compromised stability of the tib fib, when we go up into plantar flexion, again, those two bones are going to have to work around as the talus works under them, okay? So again, if there's any trauma there, those tissues will be stimulated. Again, if there's nociceptives present that are sensitized, that surely will go up and the brain will interpret it as some kind of perceived threat. So what I find usually with the syndesmosis is, Pete, if you do a normal calf raise for me, okay, is do it on single leg, is the athlete won't be able to do a calf raise, okay? What they'll find is they'll end up almost like this, where they'll feel, they'll go like that almost, where they want to do it, but their system literally won't let them develop the torque to actually do that movement itself, okay? So then that would be, in my mind, going, okay, there's probably some instability here. Then, you know, I definitely want to get that athlete off this foot and give it an opportunity to nip back down, so to speak, okay? So you're going to see this kind of, where they'll almost try to do that and they'll be able to go a tiny little bit, but the athlete will not be able to do a calf raise. Whereas if you can go right up on his toes, so if you can hold on to the wall and then go right up for me, okay, if the athlete can display that and he's got good intent there, then I'm pretty happy, okay? But that's one of the things that we want to get back before we do any hopping in my own rules and my own return to play, okay? So we want the athlete to be able to get a full calf raise before he gets back returning to play, and we're going to talk a little bit about that later on this month, okay? So that's another test that's very, very valuable for the syndesmosis, okay? If they're positive with either the squeeze test or the dorsiflexion external rotation test, but you know, you're not quite sure, then when they do the calf raise test, if they don't have good intent and they can't really get up, you know, and they almost have this where they're almost trying to think about it, then that for me is a good sign, you know, from my own experience, that they probably have a syndesmosis, okay? Now we need to be careful if it's day one post injury when we assess them, okay? Because the chances are it could be pain inhibition as well, okay? So if they come back in the day after or 2 days later, they may be able to do it, okay? If there isn't the genuine syndesmosis there, okay? So if they're, you know, they can't do it, you know, we don't panic, but we are very, very suspicious of a syndesmosis, okay? If there wasn't a syndesmosis and it was just a general ATFL or an inversion sprain, we still want to check the ability to actually go up on the toes, okay? And when Pete goes up on his toes here, what I'm looking for is, does he have good intent through the ball of the big toe and the ball of the little toe, okay? So what you'll see with a lot of athletes is that they'll tend to bias one. So with an acute ankle sprain, Pete, if you go up again, but I want you not to put too much pressure through your big toe and just put it all through your little toe as you come up, okay? You'll almost see them where they're over on that outside. So you can have your little toe on the floor if you just move out of the way. So what you'll see is this kind of almost where they're over here, so they're almost excessively inverted, okay? So again, that just tells me that they don't want to put good pressure through the big toe, and we're going to show you a little test for that as well now that I do, to actually restore the ability to push through the big toe, because we want the peroneals to generate torque again straight away. So obviously if you think about that ATFL sprain, the system is going to try to protect that injury. It's not going to want to generate torque around the injury for the first few days, whereas if we can get the system to restore, reassure it that it is safe to put torque around those tissues that were injured, then that may help decrease the amount of motor adaptations that happen as a result of this ankle injury, okay? So the syndesmosis, squeeze test, dorsiflexion external rotation, and then use the calf raise as an assessment, okay? I'm not a big fan of using calf raises in rehab, but I use the calf raise as an assessment. I think it's very, very valuable to see, number one, have they got intent to actually get up there, and physically can they get up there? And number two, have they got good intent through the big toe? Are they genuinely pushing through that big toe to generate torque through the peroneals, okay? And if they're not, you'll tend to see excessive supination, and you know, that's, in my opinion, it's just motor adaptations where they're working around it, but they don't have that good intent through the big toe. Okay, so I hope you found that useful. As always, keep it simple, clinically reason at all costs, and at all times strive to find what's not doing its job so that you can allow that ankle joint to distribute load in all directions without any perceived threats. If you found this content useful, as always, head over to thegotofysio.com. I've got plenty of tips and resources there for you as well. So the next day, in the next lesson in the content, what I'm going to do is I'm going to talk to you about the importance of the peroneus brevis, tertius, two very, very important muscles that are often overlooked and can still cause a lot of issues for muscles up the chain if left untreated. So with that said, I'll see you on the next episode.